Welcome to our clinical care session for Collagen 6 and Maricin deficient related CMDs. And we're supposed to have a large group here, and I know there may be some questions that are more specific to Collagen 6 or Maricin deficiency, but we wanted to have an open forum, and we're going to actually start with some comments coming out of questions we've heard during the weekend, and then of course we have a microphone that's going to be circulating around for you to ask questions. This is a great opportunity to ask questions. A lot of things will overlap for both conditions, so I think it was helpful to have this forum together. Two of our colleagues need to leave on the earlier side by noon, so we're going to start with them first, and that's Dr. Hemant Sawnani from Children's Hospital. Is that right, Sawnani? From Children's Hospital of Cincinnati. I always say his name wrong. A wonderful pulmonary colleague with great neuromuscular expertise, and Dr. Kaul, also from Cincinnati Children's Hospital, a GI physician. So they'll start us off, and then Dr. Jim Collins and Dr. Russ Butterfield and myself will be here for the duration, and then we'll also be open for questions you have and covering all issues that may be concerning. So do you want to start off, Hemant?
Can you hear me? I was just wondering if there were any specific questions, really. A couple of points that I think need to be strengthened is some of the feedback which we can go over, but if there are any specific questions, we can cover that as we go along. So, the summary of what I think we have discussed over the last day or two is proactive care, and that requires more frequent follow-ups. We typically like to see you people within, on a 6-month basis at least. I think 12 makes, they say distance makes the heart fonder, but it's really uncomfortable sometimes when we know that things are evolving and we can't see you to alter our interventions or the intensity of our interventions in order to adapt to progression or change. So even if it's harder to see the physicians on a regular basis, I think communication is really helpful. On a separate note, I'm actually working with the MDA to build a neuromuscular telemedicine system. And our first pilot actually was with, it's now about a year that we've been able to do this with a smaller place in Duluth, Minnesota. And it has worked out fantastic. We have been able to alter trajectories within a year for some of the patients we've seen over there. And I think at some point, this becomes leverage for the MDA, perhaps the PPMDs, the Cure CMDs of the world, to lobby for a universal telemedicine license that really makes it feasible for us to get to your individual MDA clinics a lot faster than going through a process that takes months to years. As far as the care is concerned, the focus of pulmonary well-being becomes cough assist and early assessments for initiation of nasal mask ventilation or invasive ventilation, however the case may be. The escalations in therapy with illnesses, intercurrent illnesses, or with elective procedures is important. And we are actually, so last night we actually had a meeting and are working on a document with Rachel at the helm, pointing a gun at us. No, not kidding, not so hard. To come up with some sort of guidelines that makes it easier for the families to access as to what needs to be done on a regular basis and how do you escalate care closer to surgeries with an illness. And so, at least in our practice, in the regular world of pulmonary medicine with asthma, people are given an asthma action plan. It includes a green zone, a yellow zone, and a red zone, and a plan of action. We have recently been piloting something similar for our trach and vent neuromuscular patients at Cincinnati. It seems to be working well. We're working out the kinks, but I think that's something that we are going to build up towards and maybe float that up on websites. It's a very general guideline. Everyone's situation may be slightly different, but the principles are going to be what things could be escalated electively going towards surgery to get you in the best possible shape, getting off surgery, getting off the ventilator in the ICUs, and getting back to your home managements. A thing I'd like to say about the use of oxygen, while we work towards a document that we can pretty much hand out to families to say, always keep this with you and take this to the ER when in doubt, show it to your physicians over there. Oxygen should not be the mainstay of respiratory support during an illness or during any stressor. And when I say stressor, I mean even just a simple fever. If you think about fever, it actually is like turning up the temperature in the body, which means your heart rate increases, your breathing rate increases. And that requires you to extract more oxygen from the lung into the blood circulation and transport it very quickly to all your tissues, which are functioning at a little higher rate or burning calories at a higher rate. So the two things that you do need are good oxygen support as well as calorie support during these events. Calories ideally should be a little more sugar and less fat, because fat tends to delay gastric emptying, and that can lead to early satiety, and you can actually reduce your caloric intake, net caloric intake, if you're not careful. So during these moments where you actually burn calories faster, having something that is easy to burn and easy to digest is helpful. So oxygen on a daily basis. There is so the way we describe this is the pulmonary mechanics are an issue, not the lung tissue. The lung tissue becomes a problem only if there's recurrent or chronic aspiration that is healed with scarring and leads to recurrent chronic bronchitis. It is very rare for people with normal lungs to need oxygen. If there is a need for oxygen, your saturations are lower. The undercurrent message is breathing support is not yet optimal, and that needs to be optimized. So we use saturations more as a guide for how well we are ventilating people and how well our breathing is in general. For your saturations to go from 100 to 95, it requires a minimal change a mild change, not minimal, in the actual oxygen level in your blood. But when it goes from 95 to 90 or below that, there's a much more significant drop-off in oxygen content in the blood, and that, to me, is an indication of carbon dioxide levels going up. Remember, the amount of air pressure in the lung is very finite. Okay, so all this air that we have around us, 21% is oxygen, a very small percentage is carbon dioxide. But if you were to increase, the rest is nitrogen. So if your nitrogen content stayed the same, but you increase the carbon dioxide level in this room, the oxygen content would have to go down for the sum total of all the pressure to be the same in the room. And the same is true for the lung. We look at gas pressure in the lung. There has a finite amount of gas pressure, and if your oxygen concentration drops, it's going to be usually at the cost of increasing carbon dioxide levels. There are other reasons why this could happen, which would include collapse of certain segments of the lung, but that again is an indication for why we need more pressure support rather than just adding oxygen. When we do have some people on support, we may add oxygen during an illness if their ventilation is otherwise normal, and that's really just to cope with the stress of the illness so that your heart rate doesn't have to go up that high, or you don't need a higher respiratory rate in order to compensate for that.
So the take-home message would be usually decreased oxygen saturation indicates a need for increased pressure support.
That's correct. So again, this is about style. I tend to keep a lower threshold to respond. So when my patients in the sleep lab have an average saturation of 96, 97, I don't like it. I always feel there's room for improvement. And that's not by adding oxygen. Unless it makes it really uncomfortable, I would go up on the pressure instead. So those are things that I think about, because with pressurization, you also get better lung what we call recruitment, and you prevent collapse. Collapse in the lung is very interesting. It starts, once it starts, it usually tends to progress unless you intervene at some point. That's because what we call regional compliance begins to change. Certain areas of the lung get stiffer, they get harder to expand, so air takes a path of least resistance and goes to the other areas that tend to expand easily. And that's the reason why we kind of are careful about just adding oxygen blindly.
And if you go to the ER and you're short of breath and they put on oxygen, that's usually not the right approach for collagen 6. I should say it's almost always not the right approach for collagen 6 patients or Marison deficient patients. Is that right, Hemant?
So I say that oxygen may be helpful, but in conjunction with pressurization. And so this is a really important point. What we started doing is actually giving our patients 2 settings on some of the capable machines. I give them a well setting, and when you're sick, there's a separate setting. So they switch to this secondary mode or a sick ventilator, and that's possible with the trilogies or some of the astrals, depending on what ventilator you use. I have no problems teaching families or walking them through the process of troubleshooting some of the setting changes on the phone. And the reason is really just to tide over this illness crisis. If you think about a cold, whatever happens in the nose, there's a good likelihood it's going to happen down here. In all of us relatively normal individuals, if I did lung functions on any one of you when you had a cold, you'd be very different from when you are otherwise well. So there's no reason to think that this doesn't extend into the neuromuscular population. And that's why having a slightly different setting, which means a little more support when you are ill with pressure, is generally the first step I go to before just blindly adding oxygen and leaving you on the same pressure. If you're collapsing lung units on the current home setting, there's little likelihood that you're going to open up on that home setting unless I increase the pressure.
So is pressure your friend more than oxygen? And particularly if you're in an ER or a hospital and they're sending you home with oxygen and not pressure support, that is a red flag for all of us up here. And so that would be a huge take-home message. So don't agree to just go home on oxygen or be on oxygen in the ER when you're short of breath. You have to have the concomitant, at the same time, the increase in pressure. And
part of this also requires increase in cough assist treatments or airway clearance regimen on the side. So you are going to be subjecting to the individuals to increased pressures through the day off and on. Now, the one thing you should know is that if you do have oxygen at home, there is a small adapter with a little nipple that does come along with the cough assist circuit that you can add in place right close to the mask or at the base to the machine where it connects to the filter, and you can actually bleed oxygen into the tubing while you're doing cough assist treatments. So that's something to think about, that you can, if someone's using a little oxygen when they're on their pressure support, you can always continue to add the oxygen during the cough assist treatments. Sorry? Oh, it's a little blue, so typically it's a blue, transparent blue T adapter that comes along with the circuit that comes with your cough assist, the tubing and the mask that's in the bag. It's usually a kit. So there's a little blue piece that actually connects to, you can connect it at either end. Most families, most of the time we recommend connecting it just after the filter, which connects to the machine. And you can bleed oxygen from the tank or a concentrator right into that. And typically with the cough assist treatments or on BiPAP, you would use anywhere from 1/2 to 2 or 3 liters because it's a fairly high flow. It doesn't really give you that much of oxygen. A lot of it is being lost during the exhalation process. So it requires a little higher flow just to help you during that process.
Can you repeat the question?
I will. So the question that was asked was what that adapter was. I'm not so sure there's a name to it specifically. It's like all the plumbing related to pulmonary supplies is just called an adapter. Yes?
So when my son gets sick, we automatically bring the BiPAP with us to the ER just in case.
Yeah.
Do you have a special way that you adjust? When my son gets sick, we automatically bring the BiPAP with us to the ER or wherever we're going. And so I was wondering, for the sick plan, is there a certain way to figure out which numbers to up by a little bit? Or, because I've asked the doctors for this and I haven't gotten anywhere, so I need a say.
Yes, there is. But it really needs to be taken in context with what they're seeing. If someone gets sick and has much more collapse associated with that from a pneumonia or from a mucus plug, yes, there's an oxygen requirement. They usually are very uncomfortable. In such a situation, the chest rise may not be as adequate, and we may elect to increase that lower number and the upper number at the same time. For some people, we may only increase just the upper number for a little while. So we need to see somebody before we can actually do that.
That's part of the problem. The doctors are scared to make the call, up this, up that, and then...
So, there's this great line that comes to mind. It's from the movie Point Break, the original one. It's when they were about to jump from the plane with a parachute. Patrick Swayze and Keanu Reeves, and he says, fear causes hesitation, and hesitation causes your greatest fears to come true. And that, I think, can be expensive because it can make the difference between somebody not needing an ICU admission versus somebody needing an ICU admission. We discussed this very superficially yesterday. It's hard to get all practitioners, especially if this is not their routine practice. An ER doc doesn't really engage in outpatient ventilation management. It's just not what they do. And to get them comfortable is individual. It's what Dr. Hank Mayer said yesterday is be the best advocate you can be and be a difficult parent sometimes for your children. But I think it also comes to the point is that we're working on this document that I think would be helpful for families to take. And at some point, I think we need to circulate that and say, is this something we can give to our families as practitioners? And then individualize it and say, this is what you need to take with you to the ER. So it becomes a written instruction for the people who assess the child that say, okay, these are things I need to be thinking about. And there are some practitioners that are doing this now in the community, talking about very specific things that need to be done, as well as a phone number to call.
It's actually a great segue, Hemant. So I failed to mention that. So Dr. Jim Collins works at Mercy Hospital in Springfield, Missouri, and Dr. Russ Butterfield works at University of Utah. And I work at NIH with Dr. Karsten Bonneman. And the three of us are neuromuscular physicians who've studied collagen 6 and Marison deficiency in great detail and the natural history of these conditions. And so that point is huge. And so you are going to know much more than most of your physicians about your condition. And don't be afraid to be bold and tell them, actually, no, that's not the right recommendation for my child based on the physicians who've studied this condition in great detail. So, for example, Jim, maybe you want to talk about Marison deficiency and the natural history of pulmonary function.
Yeah, so one of the things that we have looked at in a large collaboration group, both in the States and in Europe, we were able to pull together about 64 patients with LAMA2 CMD. And what we noticed from that experience was that we really found two basic if you just grouped kids together, two functional groups of patients, those that were walking and those patients that were needing wheelchair for their mobility, and those that were walking, their pulmonary function really seemed to, for the most part, remain stable for long periods of time, and it was really the patients that were needing mobility devices to mobilize. Those were the patients that we were most concerned about with their pulmonary function tests, and that they tended to have much lower pulmonary function as far as their vital capacity. And so those were the patients, and they also tended to have a very predictable decline over time. we also noticed in that cohort was that there was a range of patients that were started on non-invasive ventilation, and it ranges anywhere between the age of 3 on even up to age 18. And that may be due to different practices in both the States and in Europe, but on average, a lot of children started their BiPAP somewhere around the age 10 to age 11. So we learned a lot that really at any time we really need to assess pulmonary function in patients with LAMA2, especially those that are not walking. Really at the first onset of meeting your child, we need to assess that and over time and follow their pulmonary function test when to initiate non-invasive ventilation.
And would you say, Jim, for the complete Meriston deficiency patients who are wheelchair dependent, it's pretty much uniformly necessary to go on to non-invasive ventilation, but just the question is more of like timing?
Yeah, I think it's a timing, and we found really two specific groups, those that were using both ventilation and those that were not using non-invasive ventilation, but we think that it was probably just a continuum and a spectrum of when they needed to go on ventilation at some point in time. Some kids just, they don't require it early on. They tend to have a little bit higher functional vital capacity, but over time we still saw that steady decline. So at every visit, I think it's still very important for patients that are wheelchair dependent to really assess their pulmonary function at each visit.
I should just add for the Call 6 patients, that certainty is there for the Call 6 patients too, that absolutely every Call 6 patient will need to have non-invasive ventilation at some point. And there's this big disconnect, I think, sometimes with doctors that don't know these diseases and the specifics of the disease. And if they know some things, like to take Duchenne as a model, most patients with Duchenne, they'll have that same ultimate need for non-invasive ventilation, but it happens after the loss of ambulation. And so if they're taking that as a model, they're going to miss some things that are really unique to the CMDs. And that's true for Collagen 6 particularly. That need for non-invasive ventilation happens before a loss of ambulation. So we have to be paying attention long before we would, like in a Duchenne patient who's walking. We have to pay attention to these things. And Dr. Foley did a really nice study a couple years ago, a similar study to what Jim talked about with just taking a large cohort of patients and following their respiratory decline over time. And for most Collagen 6 patients, that happens a couple of years even before they lose ambulation. And Reghan could tell you more.
Yeah, sure. Yeah, no, it's a huge point. So I would say, and this is one point that kind of would transcend both Collagen 6 and Meriston deficiency. So for Meriston deficient patients who are wheelchair dependent, there's going to be need for BiPAP, and so you need to be proactive, look at your pulmonary function, look at that forced vital capacity, the FVC number. That's your most important number to look at. Look at the percentage on your report. So if the percentage is 50%, that's kind of our cutoff for you. We know at that point, or if you're there 50% or below, you should definitely be on nocturnal BiPAP. And the same for Collagen 6. At 50% is that really important cutoff. Actually, if you're at 60%, you should be preparing for BiPAP. And our whole goal is proactive care and not reactive care. And that's based off of the study we did with a lot of the data that we shared. It was the US, it was the UK, Australia, Belgium, and France, and it was over 100 patients with Collagen 6, and it's uniformly needed BiPAP. There's not going to be a question unless you're a Bethlehem patient who's mildly affected and ambulating to your adult years. But for all the other Collagen 6 patients, it's not even a question. We know we need BiPAP. And so I get so passionate about this issue because I get phone calls and messages every week from families across the U.S. and also internationally where there's clearly a need for BiPAP. There's a forced vital capacity of 30%, but the doctor is saying locally, oh, I don't think you need BiPAP. But that doctor doesn't know your child's condition, but we do. And so in that situation, I think it's really important to reach out and say, actually, I know my child's condition, or reach out to one of us to intervene and politely say, here's the data. There's no debate here. And so that's why it's so crazy. 2017, we have data for many, many decades that those children who do not get the appropriate amount of support are more vulnerable to chest infections. And thankfully, with the cough assist, it's been like the miracle worker for us. And I say this to all of our patients. it's prevented a lot of head colds from going to the chest. And so what's up here can oftentimes come out with the cough assist, the insulation exfoliation, instead of going down to your chest and hanging out there and causing a severe chest infection. And I say this based on a lot of data of patients who were not given appropriate support, looking at retrospective data, and sadly succumbed to chest infections which were completely, preventable if they had given the appropriate support. And so I think we know our patients, and you know your conditions, and I think it's important to say to your local team, unfortunately, we don't have Dr. Sawnanis around the globe, and so most pulmonologists know asthma. I'm getting cut off here. Obstructive sleep disorders, and oftentimes your sleep study will say this is consistent with obstructive sleep apnea. Again, that's a probably incorrect interpretation. It's really a child who's having hypoventilation, and we know that's part of the condition. Our patients, LAMA2 or Mersin deficient or collagen 6 deficient, don't have, by and large, obstructive sleep apnea. And your doctor may say that's what the sleep study showed, but no, it's interpretation. And it's kind of an issue that I know Hemant's trying to address as a sleep physician. Basically, the important thing to know is BiPAP is what's indicated, and never CPAP. CPAP is not going to help. It has to be bi-level positive airway pressure. And I always say I wish I could fly a blimp through the sky, because every week we hear, oh, I'm on CPAP, or I have obstructive sleep apnea. But we showed this report to someone like Hemant, and he says, no, actually, this is clearly increase in CO2 when they're in deep sleep, maybe a little bit of a dip in the oxygen, or little apneas. Those are all indications of hypoventilation. And the reason why this is so intrinsically important is the number one cause of morbidity in Mersin deficiency and collagen 6 is respiratory or pulmonary issues. And this is completely preventable if you're armed with the right information.
I think also we should have talk about the other end.
Hey, I have both ends, not just the other end. All right, so I'm a GI. I have less than literally 5 minutes before I leave. So I'm going to just highlight some of the things that I've learned and have kind of listening to all of the experts here on the table. I'm by no means an expert. I'm still learning. And what keeps coming back is preventative, preventative, preventative. And I cannot just sit here and not tell you that nutrition is the foundation of all of these complications that you're talking about. If you have poor nutrition or failing nutrition, or your nutrition is compromised in any way, it affects your muscles, which in turn affects your respiratory function, which affects your mobility, which affects your heart, which affects literally everything, every system in your body. So I cannot stress upon you how important the nutrition is in all of your children's care. A lot of times, people, what we talked about last night about G-tubes and when do you place G-tubes and all of those issues, so I'm not going to harp on that, but just kind of highlight that nutrition is extremely important, and good nutrition is extremely important for your kids. Moving on to the other end, constipation. The only thing I'd like to say is, talking to most of you, your kids have constipation, and most of you have been on Miralax or polyethylene glycol, but I did not really hear anybody saying that they were on a stimulant medication, either Senna or Dulcolax or Bisacodyl. A stimulant laxative is one that increases contractions in your colon. That's what these kids need, because they cannot generate enough intra-abdominal pressure because of the hypotonia to get that oomph to push the poop out. I hope I'm making sense. So therefore, since their gut works and the contractions in the gut work, why not give a medicine that actually increases those contractions and helps you empty better? That makes sense? I'm sorry? The name of the medicine. It's an herbal preparation called Senna, S-E-N-N-A. So it's a stimulant laxative, as opposed to Miralax, which it's an osmotic laxative, which tends to keep the stool soft. That's not the problem here. The problem is to generate that pressure to push it out. So what I use in my practice is a combination of a little bit of Miralax, not more than 1 cap a day, and then add Senna to it. So it's a combination therapy. So those are the two things I really wanted to highlight after talking to everybody. Those are the two things that I was asked the most about. If there are any specific questions, I can, in 3 minutes, I could take those. Yes, go ahead. Go ahead. So I don't have a lot of experience in specifically myrisine deficient children, but talking about nutrition, not everybody needs to go to G-tube. You obviously try other oral means, try to increase calories, try to use that as your first line to increase oral calories. But remember, when you increase calories, don't just increase calories because you go to more concentrated formulas, which aren't necessarily good for you because what you're missing out is on free fluid that your body needs. So just going to concentrated formula 2.0 per ml is not going to help you. It may make it worse, the constipation especially. So yes, you're getting more calories, but you're lagging behind on your free fluid. So try to do as best as you can, but I'm a huge proponent, and I can't believe I'm saying it here, but I'm a huge proponent of relatively early placement of G-tubes to improve nutrition only because I've seen it improves their neurologic status, their, mentally, the kids feel better. The kids are not spending an hour per meal. You give your G-tube feed, then you move on. It impacts the quality of life of the entire family. And I wish I had some families that have G-tubes who could tell you, actually there was one, what a difference it made in their lives.
I actually was going to ask you a question, but
Please.
My daughter is 7 with Ulrich, and she received a G-tube last summer, and I'm a nurse practitioner. I resisted it intensely for a year, and I have to say it's the best thing we've ever done. It's been really helpful, especially when she gets sick and stops eating. So I'm just one of those families.
Thank you for plugging that in.
I just want to add one thing is that when we talk about nutrition, it's intensely important, particularly when heading into scoliosis surgery. A lot of these children are so lean. I worry about the hardware actually affecting the skin because it sits so superficially underneath the skin. You really need a decent fat pad for comfort overlying the hardware. And you also need good nutrition to heal effectively and reduce the risk of infection. So that has been an issue for some of the kids who went to surgery without having good nutrition.
Thank you. See, I don't have to. They're plugging it in for me. Yes, sir.
I would like to ask Dr. Kaul, do you have a preferred proportion of protein, fat, carbs in the diet?
So there's a misconception in the CMD population where, we need a lot of proteins. So remember, if you do a really high protein formula or a shake that you make for your kids, be careful because the high protein content can actually mess up your kidneys. So you have to then monitor. There are some formulas that have almost 50% of the calories coming from proteins. Absolutely not the right thing for your child. So there has to be a dietitian that helps you, especially if you're doing those kinds, making those at home. Yes, sir.
For those of us who are interested in improving our diet and our nutritional balance and intake, what are those resources I can turn to create my daily, let's say, routine schedule and dietary restrictions?
So I'm not sure there is a website that I could refer you to specifically for CMD for nutrition, but I think the best thing, your first thing would be to talk to a dietitian that you have in your, that works with your physician. That would be the first thing you do. And they can kind of go over your diet and say, okay, this is what I'm taking every day. They'll kind of calculate, there's a program in there, an app that I guess you guys can get it too. You put everything that you're taking and it spits out how much protein are you getting, how many calories you're getting, how much carbohydrates you're getting, and you get that whole thing. But then you also need to make sure that is that enough for you and is the proportion of each one of those appropriate through the dietitian. So I would do it with the help of a dietitian.
But with all the general different dieting guidelines out there and all the different types of diets that exist, are we okay with the dietitian concluding that a natural balanced diet is the best way to go, or are there specific diets considered for it?
So nobody really knows, and there's no consensus on that, whether truly patients with CMD need more proteins. That's just because muscle is protein and it needs more protein for its regeneration and stuff. Is that the right thing or not? We don't know that, but we tend to prescribe more proteins more than the general diet for an otherwise okay kid.
Yeah, absolutely. I used to live in San Francisco. Everything's organic, green, and blended. So
Yeah.
I'm just trying to navigate that.
So my question was about formula via G-tube. so it's only been a year my daughter's been on YouTube, and we live here locally, and we go to Children's Hospital, and they wanted to have Pediasure, and I mean, I look at the ingredients to that, and it's almost all sugar and some milk, and so I pressed to go to something else, and this Liquid Hope and other things, she really poo-pooed it, like, she said, look, people survive on this Pediasure. So she switched me over to Complete. She said insurance, anyways, I'm just wondering if you have any opinion.
I don't really have an opinion, but if it were my child, I would do a puree diet, blenderized diet at home. And only because some of the parents that have done that, the kids are doing great. There were some issues of vomiting, and I think the family from Australia had their child was vomiting a lot on that, and they went on a blenderized diet. You can make it at home. You can put all organic stuff in there. But again, with a dietitian's supervision, say, okay, you put this much spinach, you put this much of applesauce, and you kind of blenderize it at home. You make the whole day's worth and stick it in the fridge, and just take out boluses and give it through the G-tube. Personally, that's what I would do.
My daughter on YouTube, she got one before she got the spinal surgery with the rods, and she was 30 pounds, and now she's 50 at 12, and we do blended food diet, and that's helped greatly with her constipation. She doesn't have it anymore.
That's another advantage of doing the blenderized diet. It helps with the constipation. You can put extra prunes in it, which the kids hate to eat. You can put more spinach in it. You can put all the stuff you want in it, and then that would help the diet. So I'm a big, huge proponent of blenderized diet.
I actually got the blended food from Amazon.
It was
made by a TB mom, and it's amazing. And it takes a lot of pressure off of her and us. And there's days when she doesn't want to drink water, so I'm like, okay, we'll put it through your tube. It just makes life a whole lot easier.
Thank you. Unfortunately, you have to go. I'm sorry. I don't want to miss my connecting flight. Thank you.
Thank you so much. Thank you. Thanks. Thank you. Thank you so much. Thank you both. Thank you so much. Thank you.
Thank you all.
Sure, go ahead. I don't know.
What can we do as a community to make having this piece of paper to give to a doctor move faster and get it now? Can we do anything? I mean, there's a lot of people here. Can we call?
So what's happened, I can say what's happened so far, and what I've been trying to do is we do have the data for Collagen 6 published, and so I kind of unabashedly give it to parents and say, give it to your pulmonologist, or I'll send it to pulmonologists. And that data is so incontrovertible, they stop arguing. Before they see it, they think that I'm trying to tell them what to do. But actually I am, because we know Collagen 6, and they probably never saw a Collagen 6 patient. For Mayor's deficiency, Dr. Collins is working on that paper. That also be a document you can hand and say to a doctor and say, this is the data. And again, it's incontrovertible. The other thing,
and just to say, we met last night, several of us, to talk really more about the pulmonary issue specifically, and getting a paper out as soon as possible. So that's happening already, I think. And I think your voice just demanding it is good, and it helps keep us on task.
Well, I know a larger group is better than 9 doctors. Yeah. We could all.
But I think the thing that you can do now is just to advocate for your child with your doctors and say that there are specialists out there. There are people who deal with these questions all the time. And hopefully we'll have that guidance that we can just hand you something, in the near future.
I mean, and there are also clinical care guidelines for both the congenital myopathies and the congenital muscular dystrophies that are out there as general guidelines, but still helpful, especially for those that are physicians that don't have a lot of experience. It's still a good document that you can give to your physician to say, these are some general consensus guidelines, and it's at least a way to start. And also just let them know that a lot of the neuromuscular specialists are happy to take questions from your physicians. Bless you. We're happy to take questions and at any time if you have a physician who's just not sure how to approach it. We're happy to take those questions, so you can always direct them towards us.
I just had a quick comment too about the G-tube thing. I just did a lot of research on gastric bypass, and a lot of the websites talk about both gastric bypass surgery and G-tubes and how to prepare your own food and how to get enough nutrition in a small amount of food. It was like the doc was saying about the pureed stuff. I just thought I'd mention if you search for gastric bypass, I got all this stuff. That helps.
One thing I'm just going to add in terms of also beyond just advocating for your own child, the Cure CMD Collagen 6 specific Facebook group, and there's also a group called Positive Moms for Marison Deficient Kids, and it's Moms MUM, because one of my patients from the UK's mom started it. Those are hugely important forums, and there's a mom in the room here who was reading the dialogue one day and let me know that somebody needed help in our community, and she said, "Can that mom call you?" And I said, "Please." And that's important too, telling each other you should reach out, because if you're struggling, you should never struggle alone. You should reach out to one of us. If you find that your ICU doctor post-operatively is telling you the wrong thing, it's not uncommon that we hear after scoliosis surgery parents are panicking at bedside. The ICU is threatening to put in a tracheostomy. They're not knowing what to do, basically. We know what to do. It's actually a formula. We know that we should be extubating to BiPAP and then being patient until the child's ready to come off of BiPAP. There's no reason to be threatening a tracheostomy in patients that don't need a tracheostomy who've been on non-invasive ventilation. So you should never be struggling or anxious alone, because we know what the natural history is of Marison deficiency and collagen 6 deficiency. We know actually what's worked for patients. That knowledge is very important, but I think one great forum is the parent forums, as well as reaching out to your local neuromuscular physician. Thank you. Thanks.
So our 11-year-old daughter, they're getting ready to do the spinal fusion. I guess my question is, if you get in that situation, you're in the ER or wherever, and they do that, what do I remember? What do I do? Who do I call? Is there like just a number to call, or what do you do?
Yeah. Or how do we get that paper ahead of time?
Well, I think Jim and Russ would agree with me. I think what has happened in my experience is that usually the parents do frantically call the neuromuscular doctor, and that's perfectly fine. And I've had to have big debates with surgeons and ICU doctors and to convince them to trust that we know what's going on. I think you do call your neuromuscular doctor. What do you think?
Yeah, and I think one thing we try to do is just to make those recommendations in advance of the surgery. So often we'll try to have a conversation with the anesthesiology and the ICU staff so that things are already set up. Go ahead.
You said you already had the Collagen 6 documented.
Yes.
Where can we get a copy of that to hand?
Sure. Actually, it's open access. So if you Google natural history of pulmonary function in collagen 6 related, so history, pulmonary function as your guide words, and then in collagen 6 related myopathies, and that will come up.
Right, and that's a scientific paper about the decline in respiratory function.
So it won't make sense to us, but hopefully we can.
It would make sense to your
Right.
doctor. Yeah,
and I think
exactly.
the key things that particularly come out of a surgery is that you extubate to BiPAP, so you can emphasize that to the physicians taking care of her from the very start, and reiterate, this is the plan, and make sure that they know the plan.
Yeah, and I think Russ brings up a huge point, is that if you're contemplating any surgery, is to have all these conversations prior to the surgery, and we really recommend that you get clearance from your cardiologist, your pulmonologist, and have a consultation with the anesthesiologist, of course your neuromuscular specialist as well, prior to any surgery. And to have a plan going forth. Now it's easier at the larger academic centers because people have already put in protocols. But if you're not in an academic center and you're doing the surgery outside of that, is to make sure everything is covered prior to that surgery, so that that you already make contingencies if something was to happen either during the surgery or after the surgery and extubation to the BiPAP, because sometimes you need to make sure, especially if kids have difficult airways, if they have neck extension contractures, their airways may not be in the alignment that they're used to, and so that's huge to make sure that the anesthesiologist is aware of, so they can be at the bedside at the time of extubation.
It's a huge point that Jim makes. He knows by experience too, and make sure when they extubate, it's not at 2 a.m. It's not after lunch when the anesthesiologist is in a case in the OR. You do it at a time where everyone's around and ready to, if need be, when they extubate, there's struggles. You want an anesthesiologist at bedside. And also, it's important your neuromuscular doctor knows the date of your surgery. Recently, when this patient in particular was struggling, I reached out to the neuromuscular doctor, and that doctor had no idea their patient was undergoing surgery at that time. You should make sure that that date's known to your neuromuscular doctor. And one thing is email is very powerful. I was able recently with one patient to copy in the anesthesiologist, the surgeon, the pulmonologist, and tell them, based on our experiences, here's what we recommend, and a kind of itemized list what to do.
Right, and even in our center, just to tell you that they often won't call. So even if I know the date, then I won't remember. So if you remind those people to call the neuromuscular team and let them know you're in the hospital, that helps us to know that you're there, and we can reiterate some of those recommendations.
More questions?
Article 2000 in 2013?
Yes.
Okay.
Yeah.
So
Yes.
it can be posted on that Facebook group for me.
Yes. Yes. You can do it. Perfect. Okay. Thank you. Thank you.
Print this out.
Yes.
Bring it with you.
Thank you. Are there questions that we could help with? Usually, yes. Yes.
Mine concerns energy, and other people I've talked to get really quite, with collagen 6, get quite tired. And do you have ideas to increase the energy?
I've heard from our adult patients, I'll cover this actually in the adult session as well, that's one thing, kind of pacing yourself. It comes up as you get older, but I think as you're, your kind of limits, I think it's more of pacing yourself. We do have one collagen 6 patient who had a routine of doing kind of every day a little bit of low impact kind of exercises, nothing over the top, but stay conditioned, and then a balanced diet, what we could recommend, but beyond that, I don't know.
Yeah, I think low-level exercise and activity is good, and I think these issues of pulmonary and nutrition are really the centerpiece of that. Obviously, we won't be able to make you like normal, but we optimize to the level of function that you have, and that pulmonary and respiratory are probably the biggest aspects of that. And a light sort of exercise schedule is probably a good addition.
Yeah, I think nutrition plays a huge role there as well, depending on the types of foods that you're eating, especially if you're eating a large carbohydrate load that can really be fatiguing. Some people may also recommend some supplements like coenzyme Q10 and riboflavin, which help with the energy side of things, that boosts your mitochondria. That may or may not work. It's not harmful. So if you do try it, give it a month or two. If it helps, keep it going. If it doesn't help, just let it go. So those are some other things you could potentially try.
Any final questions, comments?
So a lot of the information I'm receiving throughout is very academic and very interesting, but there's a lot of issues that I'm having translating a lot of these things into application in my life. As this research is just kind of flooding in right now, which is really excellent. So thank you, by the way. Is there sort of like, how does somebody who has not spent their life going into like the academic research side of things get information that is more like that can use more practical use and translated that way?
I would say again, your best resource is really each other, because there are those who are older than yourself who are on I know that Collagen 6 Facebook group. I have a whole cohort of patients in the UK who are more than happy to tell you what they do from a day-to-day basis. One thing I think I just want to mention as a comment is that by and large, we as clinicians are always impressed by our patients, particularly the Collagen 6 Mersin deficiency patients, that you fulfill your dreams. And so when we see you back in clinic and we hear what you're doing, we learn a lot from you. And so our goal is to help you fulfill those dreams. But by and large, you're all kind of, I should say, clearly high achievers. And you learning from each other nuances of, how do I go back and forth to work? How do I kind of figure out the metro or the bus system? Or how did you do this? Or what adjustment to your wheelchair? I mean, clearly that's what we've learned through the years watching all of our patients grow. So I think that's a really good day-to-day resource.
Yeah, I think you guys are your own best resource for some of the practical aspects of living with these disorders. And, I'm constantly amazed by how, the ingenuity of people to solve problems and figure things out. And we don't live with that every day, so we don't have that maybe sometimes practical knowledge that you guys will have and can share with each other. As far as dissemination of the research and stuff, that's why we're here, so hopefully get you guys up to speed on some of the things we're doing and communicate with you guys about new developments and new research and things like that.
And one thing you can do is try to kind of keep your care as optimized as can be, because when clinical trials start to enroll, I mentioned yesterday, it's really important that our patients do have a good level of care, that they're not coming to us and we realize, gee, this person should have been on BiPAP 5 years ago. We want to make sure that we're optimizing, we're caring for our patients and you're caring for yourselves to the best of our abilities, so when treatments come, we're ready to kind of go right on in and not worry about other things that should have been looked at before.
Hi. Okay, I've heard a lot on Facebook about Botox, and there's been a lot of discussion. Half of them say, yes, it's good to try that, and the other half say, absolutely not. And it's my understanding that we should not be doing Botox injections. Can you please tell me what the real answer is?
Don't do it, I would say. The purpose of Botox is to weaken muscles. Right, and we use that in patients with spasticity, and that the purpose of that when you have spasticity is that you have a muscle inflection and a muscle in extension, and those are out of balance, and so we weaken one of those sides so that you can have a better balance of those things. That's really not what's happening in any of the muscular dystrophy situations, right? We already have weak muscles, we have fibrosis in the muscle, and usually the Botox won't help those things.
When I get sick, my doctor first thing will put me on steroids. Should we be taking steroids? Should we not? Never.
I probably get to, I'm very passionate about the pulmonary issues. No. So I think pulmonologists, by and large, treat certain conditions, and neuromuscular is not one that they commonly come across. So they go back to the recipe book for what they know. And I don't blame them, but they don't have a chapter, I don't think, from my experience on Collagen 6. And so steroids would not be indicated. Again, the key thing here is not lung disease. The parenchyma, the lung tissue itself, should be fine. It's the intercostal muscles between your ribs. It's, by and large, for Mersin deficiency, actually, it's weakness of those intercostal muscles. For Collagen 6, it's inordinate involvement or extreme involvement of the diaphragm. So for Collagen 6, the diaphragm is very weak, in combination with maybe a difficulty expanding the rib cage a little bit because of contractures in Collagen 6. So steroids would be treating the lungs, not muscle weakness. So in the setting of illness, it's going to be cough assist would be really, really key. And maybe if they're early initiation of antibiotics, but not steroids.
Yeah, the steroids are really treating from a sort of an asthma perspective, right? And some people have asthma, so if you have asthma, then maybe steroids are okay, but it's not going to help. And I think Dr. Foley's right, is a lot of the pulmonologists have a playbook, and that playbook is largely driven by asthma and cystic fibrosis. So those sort of interventions are going to be the things that they see first, unless we can educate them differently.
Hi, I just wanted to readdress the Botox issue for one moment. So I can really appreciate what you said in terms of the application. I just wanted to share also that Alex had 2 series of Botox injections in the salivary glands and at CHOP, and probably out of everything that we've ever done, that was like the biggest quality of life changer, because he went from wearing scarves constantly with a lot of excessive saliva to not, minimal maybe when he's tired or, but it was a huge change. But it was very localized, and that's...
Yeah, and that's using Botox for actually a different purpose, right? That's putting Botox into the salivary glands that in some way paralyzes those glands so that they don't allow secretions. There's a couple different issues when you think about secretions and handling secretions to consider. And in some sense, secretions are good, right? That helps you to get rid of stuff. There's different options, including Botox. Some people use a drug called Robenol, which thickens the secretion. Sometimes it actually makes it harder to clear things, and so we tend to avoid that a little bit. We've also used atropine in some patients.
Which he's allergic to.
So it just depends. You have to just find a balance there between that thickening of secretions and putting up with them.
Yeah, I would say the Botox you have to be careful with as well, because that can dry them up too much. So it's you really need that.
Right, and then dental issues and all of that. But
Exactly.
I think after weighing all of those concerns, that seemed to be the best option, and it was really like a life changer. So.
Yeah, I remember that. Yeah, I do. One thing to mention when you talk about you had asked about the Botox. Your doctor said Botox indicated. The reason for the kind of neuromuscular injection of Botox is not indicated for collagen 6 or myristin deficiency is there's muscle weakness, and if you kind of cut off that message from the nerve to the muscle, you're going to only aggravate the weakness. And so well-intentioned orthopedic surgeons will say, let's do Botox. But again, their playbook doesn't have collagen 6 chapter in it, and so it would not be helpful. It probably would destabilize your balance that you have would be destabilized. And I've seen, devastating results from kids who get Botox or adults, and then they lose their balance that they had. So that's why we say it.
Talking about Ulrich and the diaphragm, or collagen 6 and the diaphragm, so we have a cough assist machine, and I had been told over time to do things like push my daughter's cheeks in when we do it so that the pressure is going into the chest wall. Okay, and then the last thing I've recently heard from the fellow who left from CHOP
Dr. Sawnani, yeah.
was to wear an abdominal belt to keep it, again, into the chest wall. But then my thought was the abdominal belt might prevent it from really getting to the diaphragm. So I'm just wondering if you have thoughts on that.
Well, just our experience, especially if they're lying flat with the diaphragmatic weakness, when the diaphragm is just kind of, you don't get the chest wall expansion with that. So one of the thoughts, and we don't know for sure because it hasn't been fully studied, but there are at least some case reports where if you use the abdominal binder, that may improve chest wall expansion, and so in select patients that we do recommend that, especially if we're not seeing a lot of chest expansion without the binder.
And I'm just wondering if it adds something to not have the binder to stretch that diaphragm.
Yeah, it's more the chest wall gets very, very stiff, and so if you can do mechanisms to help, especially it's kind of like a physical therapy when you're trying to stretch your child's muscles and joints. That's kind of the approach that we're trying to get at. If you're really trying to focus on expanding that chest wall to get full expansion as much as you can to help increase lung volumes.
My question is the diaphragm slowly getting stiff?
So that's a great question. I know they're telling me time for lunch, but I want to just add on to that point is we've been able to do at the NIH with wonderfully patient collagen 6 and myristin deficiency patients to do a real-time imaging MRI of breathing. And what we see in the collagen 6 patients is they exaggerate their chest wall movement to compensate for the minimal movement of the diaphragm. So you want to, as Jim pointed out, you want to use the cough assist to kind of keep that chest wall from getting too stiff, because what gets stiff really is the chest wall. The diaphragm we think probably gets fibrosis. We can't really stretch the diaphragm, but we can stretch the chest wall. Now, in Marison deficiency, it's kind of the opposite pattern. The chest wall is really stiff, and so what happens is the diaphragm overcompensates, because we compare these to patients that don't have muscular dystrophy. So the diaphragm in LAMA2 or Marison deficiency is compensating for a stiff chest wall. So both conditions have a component of that chest wall stiffness. So the cough assist really is, as Jim pointed out, is exercise, kind of like physiotherapy for your chest wall. And I know Hemant's not here right now, but typically the pulmonologists say, use the insufflation mode for the exercise and then the insufflation-exsufflation mode for bringing up the phlegm.
Yes. Yes.
Yes. Yeah.
Twice a day if you want a gold star.
Yes. Yeah. No, I agree. Yeah. How much?
You mean as far as like how often or how long? Yeah, I think for the insufflation trial, they were doing about 15 minutes twice a day, so about 30 minutes a day, which I think that Dr. Sawnani pointed out that the biggest part of at least the study that in our experience was compliance and able to adhere to that. I think it's hard for kids to do that, but if you're able to do it once a day, I mean that's awesome.
You get a star for once a day.
Yeah,
you get a gold star for twice a day.
But just anecdotally, what we notice is kids they overall just kind of feel better. Their overall tends to be maybe less chest infections, and these are things that we need to study over time to see if it really makes a difference. But anecdotally, the children really feel better when they're consistently doing the insufflation.
And I completely agree with Jim and Russ are saying. And while we're doing these background studies, it is important to recognize this conference was funded by the Patient Center for Outcome Research Initiative. Patient-centered outcomes are exceedingly important, not only to you and us, but to the FDA as well. So in the meantime, before we have all this data compiled, I think we say anecdotally is important because we're hearing this time and time again that our patients on cough assist just feel better, and I think overall we feel are doing better, less chest infections.
For those children not yet on ventilation, do you recommend the cough assist maybe prophylactically or as a preventative instrument?
Yeah. Yes.
Yes.
Yeah, I think typically we discuss it, and the family is interested in doing that we move forward. We can find ways of indicating it so that second payers will cover that.
Right, and there's aspects to that don't necessarily always apply to just clearing secretions, right? But to that sort of physical therapy to the chest wall that can be really helpful and just preventative of further restrictive lung disease.
I think so. Go ahead.
I think you're supposed to really do the titration of the cough assist initially in the office of the pulmonologist, so you titrate to a comfortable pressure, but one which is effective, so not too low, not too high.
And they've done large studies with the cough assist as far as we're always worried about like a pneumotension or something like that where you can damage the lungs, but they did a big study in Duchenne muscular dystrophy, and they really didn't find any really significant adverse events to using the cough assist, but it can be uncomfortable if the pressures are too high, so it is titrating in conjunction with your physician.
Yeah, and then certainly we think twice a day is a gold star for maintenance cough assist, but more than that is just fine, particularly if you get sick, right? And so that would be your sick day program.
Would it hurt a person who wasn't afflicted?
I don't think so.
So Dr. Hank Myers, very adventuresome, has tried this out on himself, and he's put up all the pressures, and he's still breathing and talking. So I don't think so. But again, titrate with your pulmonologist. We've always done it sitting.
I think sitting. Yeah, I think from the insufflation study that we've done at Cincinnati Children's, I think the most benefit that we're finding, still preliminary as far as the analysis, but the most benefit that we were finding is those kids that were in sitting position.
What are the strong indicators that you need to go on SIP ventilation? Like, what are the red flags We're just now on BiPAP and nighttime BiPAP.
That's a brilliant question. I don't know if Dr. Susanna Quiano-Roy is here, but she's done some beautiful studies looking at daytime carbon dioxide level. So if your carbon dioxide level during the day is getting higher, that would be indication. But symptom-wise, it would be probably best told by some of our patients themselves that are on the sip and puff, but increased fatigue during the day, maybe headaches. I don't know if you want to comment the symptoms you saw, Diane, before you went on and how it changed after.
I mean, everything changed for Luke when he went on SIP. And I think that because the decline is so sort of gradual, that in your mind you don't necessarily see the changes because I live with him every day. But then when he went on SIP, everything got better. Like his appetite improved. Before he went on SIP, what happened? You said he needs to see. I didn't think anything happened. Anna Rakowski called because his PFTs at NIH were terrible and said, you want to start thinking about this? And Luke said, no way, I'm not doing that. So it was like a 3 or 4 or 5 month process of arguing with Dr. Meyer about whether or not Luke needed SIP. And I think he's the first person to say now he was happy to be wrong.
So, yeah, it's a great question. I think it's a great point too. The pulmonary function, how low is, looking at how low the forced vital capacity is, sitting versus supine, and also taking into consideration, Dr. Meyer thinks a lot about how the function is. Is there any weight loss? Is there really increased daytime fatigue? Any headaches? That's a whole kind of combination. Or if feeling short of breath when you're speaking at long, points. I mean, now Luke's now become our best ambassador for sip and puff, but knowing we need to go on mainly off of the forced vital capacity and then maybe doing a daytime blood gas for the carbon dioxide level.
There's always been a lot of talk about respiratory issues with the Marison deficient children and collagen, but there's not a lot of talk about the GI issues. And the Marison community, the moms, we found there's more and more of us that are having children having gastroparesis, from the severe end of it to where we have a couple of children that are dependent on TPN, and then my son where we have it occasionally, anesthesia, he gets sick, the stomach shuts down, we have to, and a GJ, the J does not help. We have to go on to, he has to get a central line of some sort, and he's on TPN while we're just trying to get over a cold or RSV, but it just seems like there hasn't been a lot of study on that.
We started to do a study looking mainly at the glucose or sugar level in the blood because that's also very variable during times of illness, but a comprehensive assessment of the gastrointestinal issues hasn't been done. You're right, should be done because it is a prevalent and really important issue. So I don't know if we can convince Dr. Kaul.
Yeah, he's left, so we'll put it on.
We'll talk to Dr. Kaul about this. No, you're right, though. Yeah, it's definitely something we think about, and not everybody is aware, especially with the hypoglycemia, where the sugars can really drop in times of stress, meaning either illness, especially during periods of fasting. So that is something that we do need to be aware of and watch out for.
And just to say, these are the type of things that I think are important for you as a patient community to bring forward to us as a physician community, because we don't always see that.
And I'm not exactly meaning the levels dropping. I mean the stomach, we're just not digesting anything.
Right. Yeah. I've taken care of several patients with the LAMA2, and this would be the first time I'm hearing more about the gastroparesis. So that's thank you for bringing that to attention. We'll something to look at. Yeah.
Right. We're getting cut off here, but just to say that you guys as a community have a lot of power to help influence these type of research programs and tell us the things you're concerned about. The whole idea of PCORI, who's funding these conferences, is to foster a patient perspective on some of these disorders, because I'm a geneticist, so I just think about genetics all the time, and I'm not very good about anything else. So you got to tell us when these other problems come up, and then we can start addressing those things as well.
I just wanted to end and say, if it hasn't been apparent, we're definitely in your corner, and you won us over with your spiritedness and your joie de vivre, your love of life, so we're not going to leave your corner, but we also rely on you to help kind of keep us going and tell us what we need to be punching at. So yes, the GI issues, all the pulmonary, but we're here to help.
Thank you.
Thank you, everyone. Thank you.